good afternoon, everyone. I would like to welcome you all to the sixth progress report on my PhD thesis, which focuses on the efficacy and safety of proton pump inhibitors. My name is Elena. I'm a third-year gastroenterology resident and a PhD student here in the CDM and also at Grigore Popa University of Medicine and Pharmacy, Iași. And together with my team, we plan to improve the clinical management of patients with gastroesophageal reflux disease by assessing the efficacy and safety of acid-suppressive drugs. And for this, we have two very specific goals, which I will address in the following minutes. The first project we have started is a systematic review and meta-analysis, which focuses on the therapeutic effects of acid-suppressive drugs in adults with non-specific chronic cough. The Montreal Consensus recognizes chronic cough as a potential form of extradigestive gastroesophageal reflux disease manifestation, and it has a high global prevalence, which is estimated to be around 9.6%, causing a significant impairment in the quality of life of patients. Over the years, acid-suppressive medications, which have been proposed as a potential therapeutic options, have yielded inconsistent results, and this knowledge gap is recognized even by the most current guidelines on this topic. Therefore, our aim was to investigate the therapeutic effects of acid-suppressive drugs in patients with non-specific chronic cough. For this, we used the PICO framework, where the population of interest was adults with non-specific chronic cough, and they received acid-suppressive medication compared to placebo. And we were looking at the main outcomes of interest, that the impact on cough severity and quality of life. We have performed a systematic search in November 2022 using a search key that was comprised of three main domains. The first one was pertaining to cough, the second one to acid-suppressive medication, and the third one to the concept of randomization, as we only plan to look at randomized controlled trials, and we ended up with 11 eligible articles. Now let me present some of our most impactful results. This first figure shows the mean change in cough severity in patients with non-specific chronic cough receiving proton pump inhibitors compared to placebo. Our measure of effect was the standardized mean difference, and just as a quick tip for interpreting our results, we should know that a standardized mean difference between 0.2 and 0.5 is the equivalent of a relatively small clinical benefit. A standardized mean difference between 0.5 and 0.8 is a moderate clinical improvement, whereas a standardized mean difference over 0.8 is considered a large clinical benefit. And as you can see here, we obtained a standardized mean difference of 0.33, which was statistically significant, and this was the equivalent of a relatively small clinical improvement in cough severity. This data was derived from 9 randomized controlled trials, which totaled around 350 patients, with a relatively low estimated heterogeneity. So to sum up this first plot, we could say that there may be a small clinical benefit in improving cough severity in patients with non-specific chronic cough receiving proton pump inhibitors. We have also performed a subgroup analysis based on patient population, and we compared the patients presenting with non-specific chronic cough only to those presenting with laryngopharyngeal reflux, which may manifest with accompanying chronic cough, and we found no significant difference in terms of symptomatic response. We also performed a time dependency evaluation and saw that and wanted to see the influence of treatment duration on the improvement in cough severity. The x-axis shows the duration of treatment in weeks, whereas the y-axis shows the standardized mean difference as representative of the clinical improvement. And we can see clearly here that longer treatment durations were not associated with a greater symptomatic improvement in cough severity. The main strength of our first project is the fact that we investigated the effect of PPIs on both cough severity and quality of life, and that we provided additional insights by performing subgroup analysis and time dependency analysis. However, the relatively small number of included patients is one of our main limitations, and also the fact that the measurements of the outcomes were entirely subjective, using varying scales and questionnaires, not all of which were previously validated. In conclusion, we believe that there could be a small clinical benefit to administering PPIs in patients with non-specific chronic cough in terms of reducing cough severity, but we believe that there's no benefit from extended treatment duration. And in terms of implications for future research, we suggest more high-quality RCTs to be conducted with appropriate sample sizes and maybe even objective cough measurement techniques. The status of our first manuscript you can see here. It has been published last month in a D1 journal. Now a few words about our second project as well, another systematic review and meta-analysis. As we are all very familiar, PPIs are among the most widely prescribed medication worldwide, and recent estimates from Spain say that 1 in 10 people is actually a daily PPI user. An increased risk of acquiring Clostridioides difficile infection has been described in PPI users, with an up to 2-fold higher odds compared to non-users. However, I would like to stress out that these results were only derived from observational data, and so we should remember that these could be the results of residual confounding and other biases. Therefore, our aim was to investigate this risk, but only in the context of randomized controlled trials. For this, we used the PICO framework, and we compared PPI treatment to no PPI treatment, be it placebo or other medication, and our main outcomes of interest were the rates of Clostridoides difficile infection, but we also looked at other enteric infection and small intestinal bacterial overgrowth, and this way we plan to assess the safety profile of PPI treatment. We performed a systematic search on the 2nd of March 2023 using a search key that was comprised of just 2 main domains, the first one relating to PPIs and the second one related to randomization. In the end, we found 17 eligible articles, and we managed to perform the meta-analytical calculations on one of the outcomes, which was the risk of Clostridoides difficile infection. And we performed 2 separate analyses, one comparing PPIs to placebo and the other one comparing PPIs to H2 receptor blockers. This first figure shows the risk of developing Clostridoides difficile infection in patients receiving PPIs compared to placebo. As you can see, between the 2 study arms, there was no significant difference. And this data was derived from 7 randomized controlled trials, totaling over 25,000 patients, so a very large number of included participants, with a very low heterogeneity. So we could summarize this first figure by saying we found no difference in the risk of acquiring Clostridoides difficile infection in patients receiving PPIs compared to placebo. The same conclusion was reached when we compared PPIs to H2 receptor blockers. We also found no significant difference between the 2 study groups. These results were derived from only 4 randomized controlled trials, but still a very high number of included patients, over 25,000 patients, with a very low estimated heterogeneity as well. One of the main strengths of this second project is the fact that we assessed the safety profile of PPIs derived from RCTs only, and we provide additional insights by comparing PPIs to both placebo and to H2 receptor blockers. However, of course, we should bear in mind there's a few limitations as well. None of the studies were designed with Clostridoides difficile infection as the main primary outcome, so therefore they may be insufficiently powered. And of course, there were some variations in terms of treatment durations, doses, and follow-up times between the studies. In conclusion, we found that treatment with PPIs did not seem to increase the risk of acquiring C. diff infection, both when compared to placebo and to H2 blockers. And therefore, in clinical practice, we suggest physicians should not excessively limit the administration of PPIs when there's a valid clinical indication for acid suppression. And in terms of implications for future research, we suggest more RCTs be conducted and look at these safety outcomes and also at other enteric infections and small intestinal bacterial overgrowth. And we can see here the current status of our manuscript is it is currently under review in GUT. In summary, the first project has been published last month, and the second one is currently under review. We are waiting for their response. Over the course of these 2 past years, I have been involved in various conferences and presented my research at 2 very important European gastroenterology conferences. And also, I was lucky enough to be involved in other research projects here in the CTM. One of the papers got published, and the others are currently ongoing. And I'm also proud to say I'm an invited speaker next week at the Romanian National Conference of Gastroenterology to present a presentation on extraesophageal GERD, in which I will also present the results of our first project. I would like to thank you for your attention and leave you with one of my favorite quotes, which says that a smooth sea never made its skills healer. Thank you.
Thank you, and also congratulations to your first published papers, first authorship paper. Can we go to the timeline of your first study? Don't worry, this is a published paper, so still, if you look at this, the average is just about 0, but then there is one study which goes to the, actually a very deep increase, and then there is another one which there's a deep decrease, and then, so how do you interpret this? So what is really the truth behind? With other words, are there differences between studies? Are there bias, a certain kind of bias in the studies which they which led actually to this result. Since we try to look this critically and not only publishing but also understanding what is the real truth. So what is the real truth?
Thank you for your question. You're a very good observer of the plots. Honestly, I believe that if you look at the x-axis and you look at the duration of treatment in weeks, you can see it starts at 4 weeks, then 6 weeks, 8 weeks, and so on. And the current guidelines currently don't give very specific details about how much time you should administer PPIs in extraesophageal GERD. They just say administer a trial of PPIs up to 12 weeks. And for example, for me personally, looking at this plot and these results and these pooled results, I would personally believe that if the patient does not respond to a trial of PPIs of 6 to 8 weeks, let's say, I don't believe it makes sense or it's justified to continue to administer PPIs up to 12 weeks, considering that there does not seem to be a greater benefit if the patient has not responded in the previous weeks. So,
good answer.
Thank you.
Congratulations, and especially for the second project. If it's already under review in gut, it's a huge thing. So anyway, I have two questions. The first one is, in the first study, so it shows that PPIs have only moderate effect on this cough, if I understand well.
Small, really.
Small.
Yeah.
But actually this cough is probably, so I would assume it's due to the backflow of the gastric acid. So does it mean that the PPIs cannot adequately inhibit this acid backflow?
Thank you for your question. It's actually a very interesting mechanism. Two theories have been proposed regarding how extradigestive manifestations occur in the context of GERD. One of them is, of course, the reflux theory, like actual micro-aspiration of gastric contents flowing back to the esophagus and the upper airways. And that would be one of the situations. And the other is the reflex theory, which means that even if the backflow of acid is not up until to the pharynx, let's say, it's just in the lower esophagus, by a vagally mediator reflex, it's actually causing pulmonary manifestations. So if the effect of PPIs does not seem to be that big, we could believe that maybe the reflux theory is the one that is most probable, because even if we decrease if we increase the pH of the gastric contents, they still flow back, and there's other components of the gastric secretions and juice that come back.
I see. And the second question is, okay, now you show that probably PPIs do not have an influence on the Clostridium difficile infection, but if it would be, what would be the mechanism of action? So how the PPIs could change the gut microbiota composition?
Thank you for the question. It has been hypothesized it's because changing the chemical barrier in the gastric juice. So by elevating the pH, actually bacteria manage to survive in the GI tract more than in a patient that has a normal, very acidic gastric pH. So therefore it makes them easier for them to survive in the GI tract.
So do they elevate pH in the intestine?
Just for the gastric, it's just about the stomach, about the intestine.
But now we are about the small intestine and large intestine. So do you think that pH is influenced by PPIs in the distal parts of the intestine?
I think it definitely influences the pH and the proximal part of the intestine for sure. We're not sure about the rest of the GI tract, but in the proximal part for sure.
Okay, thanks.
So congratulations to a very nice presentation. I got two questions. First one is regarding your first topic and the definition of laryngopharyngeal reflux, if it was same in the studies or if it varied greatly among the studies. And my second question is regarding the second topic. So if I saw correctly, the H2 blocker seems to be like slightly protective factor.
It's non-significant.
Not significant, but tendency was there. So do you have some explanation why? Do you have some data that would compare H1 to PPI directly? Like H1 to PPI, like
H1 receptor.
H1 receptor to PPIs or to placebo. So what was the, so if there is an effect between those? And one more question, how do you think the population in RCT would reflect to real-world population? Were there very strict inclusion criteria, etc.? Because usually we worried about very sick patients in ICUs who could develop Clostridius, not the patients who use PPI for some, let's say, chronic cough.
Okay, so thank you for your questions. I will address them in the order that you said. So first of all, regarding laryngopharyngeal reflux, its definition is it's really related to its name. So it's the contents of the gastric contents coming back up until the upper airways, and that would kind of be the definition. However, most of the studies that we included, all of them, also included symptoms as a part of the definition. So chronic cough was part of the definitions for all of them that we included. And you could see that in the plot where we looked at cough severity, all of those were scales strictly used for measuring cough. So no measuring the laryngopharyngeal reflux as a whole. It's strictly for the cough part of the laryngopharyngeal reflux. So I think that's really good. To address the third question that you said about being generalizable, the results that we have from our second project, I think they are very generalizable just because the population that we included was very, we didn't have any strict inclusion criteria in terms of indication for PPI. We just wanted RCTs that compared PPI treatment to something else. And so the population of interest is comprised of patients that, for example, receive PPIs to see if it prevents GI bleeding, or patients under antithrombotic drugs receiving PPIs to see if it decreases the risk of GI bleeding, patients with that are staying in ICUs actually, and we want to see if it reduces stress ulcer, if it's good for stress ulcer prophylaxis. So the population that we included is very broad, very varying a lot. But still, as you can see, the heterogeneity was quite low. So they all found the same tendency, even though the patients themselves are quite different, the patient populations. And regarding your second question about comparing age to...
How to explain that?
That was very interesting for us as well. I did not expect that. I don't know what a potential explanation, if the effect would have been clinically, statistically significant would have been. But we also looked at that, and it was interesting to see. However, based strictly on the results that we have, it's no difference between the two subgroups, the two study groups. So,
regarding chronic cough and gastroesophageal reflux disease is always a big question whether we are properly selecting the patients for PPI treatment or not. Do you have any data of your cohorts? How much percentage of the patient had a proper investigation to show the, pH metry, impedance measurements of the esophagus, that they have actually a reflux disease, or just they were symptomatically chronic cough patients? I believe that if we are selecting those patients who really have acid reflux problems, they have much more benefit from the PPI therapy than what you showed us.
Thank you for your question. That's an excellent observation. Actually, of course, not all the patients that we included in these studies had pH metry done before they were diagnosed as having GERD-related non-specific chronic cough. We did perform a subgroup analysis just on the patients that we had pH testing done beforehand. It was just 3 studies. The number of patients was very low. So the results were not statistically significant. So we're not able to actually make a very big statement about that. But in real life, of course, if we were to properly diagnose GERD-related chronic cough, we would need to have pH metry done. And of course, we would need to be sure we excluded all other potential causes of chronic cough. The patient should be seen by a pneumologist, an ENT doctor, make sure he doesn't take any medications that could be associated with chronic cough, like ACE inhibitors or something like this. And this part was mostly included in the studies. They had the patient evaluated by an X-ray of the chest. They made sure he wasn't taking any medications that could explain the cough. The ENT doctor saw him as well. But that is true, not all of them had pH metry done before including the patients in the studies. The minority, yes, yes.
Okay, this kind of coughing is a tricky issue because of the air pollution and many other things. I mean, many people do cough and then get actually chronic coughing. So maybe actually, I mean, that may also play a role, I mean, in the background that, I mean, things are accumulating, like in a certain environment. I mean, just referring to this one, actually, it might be a cause, actually, that if somebody is sensitized by other issues, I mean, they may respond actually in a different way than in a very fresh, clean Norwegian air, or I don't know, German. Okay, I have a question about your second, I mean, there is an interesting forest plot in the second work. This one, yeah. Because, I mean, obviously, I mean, you get something which is a tendency, but that is actually because of one study. And then that one single study is 13,000, I don't know, 436 people, and then the other three is actually altogether, I mean, 250. Is this, I mean, I'm also asking Roland, I mean, is this really a kind of valid thing then to put this together? Because formally, yes, but again, if we look for the truth, that maybe not.
I totally agree. It's a questionable use of meta-analysis in this case.
Yeah, so there are limitations of this. I don't know how you see this.
Yes, I agree. We were discussing this also. The first study is huge, actually. It represents most of the included population. So it's obvious that the results of that study is going to be, in the end, basically the result that we get from the meta-analytical calculation here as well. So I agree.
Okay.
Thank you for this wonderful presentation. I have a question regarding the second project and regarding to your search key, that I see that you only contains the search key to domains, and you had a really hard, huge number of hits. So did you consider to put another domain into the search key to reduce it, or if it's not, what was the reason for it?
Thank you for your question. While doing the initial pilot search, when we were checking for the feasibility of the second topic, we actually found some articles that did not report the outcomes we were interested in the abstract or in the title. So if we added a keyword for the search key for the outcomes, we would have lost all the articles that did not report it in the abstract but had it in the full text. So that's why we only decided to keep the intervention and the concept of randomization, and this way we didn't lose the articles that did not report it in the abstract.
Congratulations. I also have one question concerning the second project. So, as always, we need to register Prospero, like prospectively conduct the study. Were there any specific subgroups that you planned to do and maybe you were not able? Thank you.
Thank you for your question. Yes, we plan to do some subgroup analysis, first of all, based on patient population. We were looking at comparing hospitalized patients to outpatients. We were looking to compare some details about the treatment, like various doses and durations, or regarding follow-up times. However, we did not manage to meta-analyze those subgroups because there were fewer than 3 in each, so it was not feasible. But we did try, and we registered them on Prospero as well. Thank you.
All right. Yes, please.
Congratulations on your PhD work. This is amazing. And I have a question about the second topic, the clinical implication. You said that there should be a limitation, there shouldn't be a limitation to use PPI, so we shouldn't excessively limit the PPI because we are afraid of C. diff infection. What do you think about active Clostridium difficile infection? Should we cease the PPI for the duration of the diarrhea or at the end of the disease course?
Thank you for your question. It's a very good question. So definitely based on the data that we have from our project, it's difficult to say. We could not make an assumption based on this data. However, just looking at various guidelines for C. diff and things like this, I don't remember them being mentioned, like if the patient has C. diff, you should stop administering. So personally, I don't think there's enough data to recommend stopping PPIs if the patient already has C. diff, because it is a risk factor for the appearance of C. diff. It's not a risk factor for the severity of C. diff or something like this, if it really were a risk factor. So personally, I don't think it's influencing in any way, but of course, maybe the data should be more researched and we're going to have more clear conclusions then.
Thank you very much.